Good morning, good evening. I would like to thank the teaching course of brain disease, especially Professor Ala Gerd, for having included us in this course. I'm Dr. Ricardo Allegri, the head of the Department of Cognitive Neurology, Neuropsychology, and Neuropsychiatry at the Neurological Institute FLENI in Buenos Aires, Argentina. And I will talk about our experience in our institute related with the cognitive impairment and dementia during the COVID-19. FLENI Neurological Institute is located in Buenos Aires City, Argentina, and this is the biggest neurological institute in South America. We have two sites, one on the left side of the slide in Buenos Aires City, where we have the acute neurological hospitalization and where we follow 10,000 neurological outpatients every month. And the other one, the picture on the right side of the slide, for neurological rehabilitation at 50 kilometers from Buenos Aires. Actually, we have working more than 100 neurologists covering the different subspecialties. At the bottom of the slide, you can see the people from my department of cognitive neurology. We assist more than 1,000 patients with cognitive impairment and 4,000 neuropsychological assessments each month. In this slide, we can see the profile of the daily case of COVID-19 pandemic in Argentina. Basically, we have three waves, the first in 2020, the second in 2021, and the third, the last at the beginning 2022, the Omicron variant. The COVID outbreak has rapidly spread around the world, causing a massive disruption of the healthcare system, a profound economic depression, and a distressing social situation. Most countries enter in a lockdown in an attempt to slow the spread of the virus. Based on the experience observed in Europe, Argentina closed its border on March 15, only 1 week after the first person died of COVID-19, and implement an early nationwide lockdown limiting the circulation of the population. Our lockdown was the longest in the world, more than 2,000 days, where most healthcare reserves were reassigned in anticipation of a catastrophic situation. The massive communication media and the medical community warned the population about the necessity of avoiding non-COVID consult to avoid the overload of the system. Basically, we have three problems for our neurological patients: the pandemic, the long quarantine, and the recommended by the government social isolation. On the right side of the slide, you can see the recommendation of the government: stay at home, quédate en casa, stay at home even alone. I will describe, this is my program, I will describe several subjects. The first, the neurological experience in previous epidemics. Second, the result of the pandemic lockdown and the social isolation on our patients with cognitive impairment and dementia. After that, I will talk about our experience with the cognitive impairment in the context on the neurological sequela post-COVID. Then I will talk some more about the works, our works on cognition and COVID-19. Not a lot, because Dr. Lucia Crivelli from my department will talk with you about our result. And finally, some conclusion of the neurological and cognitive sequelas post-COVID-19. As you remember, in 1980 and 1920 was the Spanish flu pandemic, and some complication possibly related with this influenza pandemic. It has been described the lethargic encephalitis, and after that, the post-encephalitic Parkinsonism. On the right side of the slide, you can see one of the magazine in Buenos Aires, 1990, showing the preventive action against the virus, face masks, etc., very close of our days. But more surprising was the data about the neurological complication from two previous coronavirus epidemics, like SARS-CoV in 2002 and MERS-CoV in 2012. In both, there were described encephalitis, stroke, sleep disorder, seizure, cognitive impairment, and Guillain-Barré syndrome. Based on this data, and the early report published from neurological complication of COVID, the Department of Mental Health, WHO, decided to organize several working groups about neurological complication of COVID-19. Dr. Alagers and myself coordinate the follow-up and long-term impact working group during 2020 and 2021, developing neurological chart for post-COVID patients, systematic review about neuro post-COVID and cognitive impairment post-COVID. Now I will share our result about the pandemic, the lockdown, and the social isolation in our neurological non-COVID patient. April 17, 2020, we wrote this commentary in the neurology blog. At that time, we were very concerned because our government closed its border and implement a very early nationwide lockdown. As we said, our lockdown was the longest in the world, with more than 2,000 days where most healthcare reserves were closed, and the health system forgot the other neurological patient, the general neurological patient, non-COVID, have not the possibility to receive the normal health assistance. As mandated by the Minister of Health, our center suspend all the non-urgent chirurgical procedure and most of the in-person outpatient visit. At that time, we decided to evaluate the impact in the national lockdown during the COVID-19 pandemic in our institute, and we published this letter to editor. The number of patients, the number of outpatient consultation due to acute or chronic neurological condition during the quarantine period was revised. We compared the same period 2012 to 2020, 2019. The number of global outpatient visits dropped 60%, and our patient with dementia dropped 66.5% the number of consultations. Related with the emergency department, the drop was 60%. As conclusion, more than the half of patients decide not to assist to the Neurological Institute, even with stroke, seizure, or tumor. This is other study that we perform. We study the change in the assistance to patient in the context of COVID. We can see on the right side of the slide the increasing of the telemedicine consult related with the pandemic. And on the left side of the slide, we can see the increase of the geographic area of influence of our department. The pandemic catalyzed the quickly introduction of telemedicine with the possibility to allow patients from distant zones to gain access to our specialized neurological care. In the same direction, we work with a representative from 12 countries from Latin America in the development of recommendation and COVID assessment adaptation for the practice of teleneuropsychology in Latin America. We launched telecognitive assessment and telecognitive rehabilitation, and we published this paper with the recommendation from 12 countries around Latin America. Other of our study, we decided to look for the what happened with the mandatory quarantine, what happened with the behavioral of our patient living in the community. We invite family members to participate in questionnaire survey. Dementia stage was classified, and we were 34% of mild case, 32 in intermediate stage, and 33 in severe stage. The most important findings were increased anxiety, 43% of the sample, insomnia, 28% of the sample, depression, 29% of the sample, worsening gait disturbance, 41%, an increase, we found an increase in the use of psychotropic to control behavioral symptoms in our patient. This is very important because our findings are related to the combination of the social isolation, the lack of outpatient rehabilitation service, and the lack of paid care, and the increase of stress of family caregiver. The next paper we published was about the high level of burden of the caregiver. We wanted to know the situation of our caregiver in the pandemic, in absence of paid caregiver and in absence of physical therapy, occupational therapy, and cognitive rehabilitation. During the pandemic, 65% of the caregiver were the family member. Overall, COVID-19 confinement increased the stress caregiver independently of the dementia stage, but those caring for severe case had more stress compared with the mild form of the disease. Family members' main concern were the severe dementia case, fear of absence of the paid caregiver during the epidemic, and for mild case, fear of spreading the disease while assisting patients. The next paper, this slide shows other collaborative study that include 3 countries in Latin America, Argentina, Brazil, Chile, in order to investigate the impact of the social isolation due to the COVID pandemic on different countries from Latin America. Related with the patient with dementia in pandemic, a significant decline in memory function has been reported among 53%. 31% felt sadder, and 37% had increased the anxiety symptom. These symptoms of anxiety were greater in individuals with mild to moderate dementia, while symptoms of agitation, hallucination, and difficulty in activity of daily living were greater in individuals with severe dementia. Moreover, compulsive obsessive behavior, hallucination, increase in forgetfulness, disturbance in appetite, and increasing difficulty, as I said, in the activity of daily living. Related with the caregiver report feeling more tired and overwhelmed during this period, and these symptoms were also influenced by the severity of the dementia. This slide shows in black the profile of positive case by age, and the red line represents the lethality by age. As you know, dementia in age-related, the most of the people die are demented patients. In this paper from Tahira and Coles, you can see that all cases with dementia had the most important risk of infection and the most important risk of death in the COVID pandemic. In this paper, we can see the relation of the ApoE for a classical risk factor for Alzheimer as a risk factor for severe COVID. And in the next slide, we can see one paper in brain that support a link between the genetic risk for Alzheimer's disease and the susceptibility to critical illness with COVID centered in one OS1. The next will be to talk about our experience with cognitive sequelae in the context of neurological sequelae post-COVID. This study post-COVID from Tucker et al. Aimed to provide robust estimate of incidence rate of neurological and psychiatric disease in patients at 6 months post-COVID diagnosis. They review more than 2,000 survivors. They review the electronic health records from patients with diagnosis of COVID-19, and they estimate the incidence of neurological or psychiatric diagnosis in the following 6 months, and they found 33% of the people with neurological and psychiatric disease. This is very interesting that for patients that have been hospitalized, the incidence was 38%. For those who had been admitted to an ITU, the number was 46%. And for those with encephalopathy, 62%. On the right side, you can see the comparison of dementia between patients with COVID and patients with other respiratory infection, and the incidence of dementia was significant different from other respiratory complications. The WHO performed a scientific brief about neurology and COVID, and post-COVID was from 28 studies, and only 2 studies follow patients for up to 6 months. Pooling was not possible for methodological reason. In a retrospective cohort, from patient discharged from hospital, 90.6% report neurological manifestation after 6 months. The complaint most common report were fatigue, 63%, headache, 44%, cognitive impairment, 28%, sleep difficulty, 26%, and anxiety and depression, 23%. The WHO performed a Delphi consensus in order to define the clinical case of post-COVID condition. And the final result was that the domain that achieved consensus were history of SARS-CoV infection with laboratory confirmation, minimum time period from onset of symptom 3 months, minimum duration of the symptom at least 2 months, symptoms and or impairment, cognitive dysfunction, fatigue, shortness of breath, and other, time course, nature of symptoms, fluctuating, increasing, new onset, persistent, and relapsing, and it's important the impact of everyday function. Okay, at Buenos Aires City is the capital of Argentina with 12 million of inhabitants. The government of Buenos Aires City have 33 public hospitals, and they perform all the PCR tests for COVID in the city. We wanted to know the prevalence of neurological and psychiatric symptoms post-COVID in community in Buenos Aires City at 6 months post-COVID infection. We have the result. We have now the result of the pilot study with 198 subjects, based of WHO clinical classification of acute COVID severity. We found the distribution of the patient based in this scale, and we found in this pilot study 85% were ambulatory, asymptomatic or mild disease. 12% hospitalized patients with moderate disease, and 2.2% hospitalized people with severe disease. When we study the complaint of neurological and psychiatric symptoms, we found in general more than 30% of the people with one neurological or psychiatric complaint. The cognitive, the memory loss was 26, brain fog 24, anxiety 33, fatigue 28, insomnia, sleep disorder 24, depression 22, behavioral disturbance 11, and even 2% of hallucination, 2% of some type of psychosis. What happened with the cognition and post-COVID? Finally, some words about our work in cognition and post-COVID. Not a lot, because as I said, Dr. Lucia Crivelli from my department will talk about our result. Dr. Lucia Crivelli, the head of neuropsychology of my department, will perform this work. We investigate the impact of COVID-19 on cognitive function in adults without cognitive complaint before the infection, and the cognitive dysfunction according to the disease severity and cognitive risk factor. We found a significant different group in cognitive composite of attention and executive function. Our results suggest that the presence of mild symptoms in post-COVID patients may persist for months after the disease remission, and argue for the inclusion of cognitive assessment as a protocolized stage of the post-COVID examination. It's interesting because it's not memory disorder, it's not language disorder, it's executive dysfunction and attention alteration. That was our result. With the working group of WHO, we performed a systematic review and a meta-analysis of the cognitive consequence associated with SARS-CoV in a population without pre-existing cognitive impairment. And we found that the cognitive impairment is characterized, as our paper, by deficit in attention, executive function, encoding in memory, and in verbal fluency, basically in attention as executive function. Disease severity predicts worse cognitive outcomes even when age is controlled, and the heterogeneity between study, the severity, and the measure at the time of assessment are limitations to have a great conclusion about the cognitive consequence of COVID-19. Finally, I'd like to share some conclusion of the neurological sequelas and dementia post-COVID to take home. The first summary is we have different types of neurological problems in COVID. First, we have previous neurological disease like dementia of Alzheimer type that will be worse after the COVID, related with infection, related with the lockdown, or related with the social isolation of the patient. The second type of patient are patients with acute neurological symptoms, both or related with the COVID, like anomia, stroke, encephalitis, or not related with the COVID, like intensive critical unit patient, maybe stroke, myopathy, etc. And the third type of patient are the long-term neuro-COVID or the neuro post-COVID, with fatigue, headache, and cognitive impairment, even with Parkinsonism or Alzheimer's disease. There are neurological complications in the acute COVID episode due to the virus or the medical situation. 33% of the patients with mild COVID have neurological or psychiatric symptoms 6 months later. The most frequent symptoms are anxiety, fatigue, muscle pain, memory impairment, brain fog, insomnia, depression, and headache. The WHO proposed that the health system anticipate this complication and prepare to reduce and to care the post-COVID sequelae. Thank you very much again for the invitation. Thank you, Professor Ala Gerst, for having included us in this course. I